This video is about hip fractures. Almost always, when a patient experiences a hip fracture, they will be unable to put weight on that hip and be in a significant amount of pain. So these typically almost always go to the emergency room where the diagnosis is made. Diagnosis is made on x-ray, typically, and at that point, the patient is admitted to the hospital to plan for surgery. In general, all hip fractures need to be fixed. When a patient experiences a hip fracture, it causes so much pain and immobilization that if we tried to treat this non-operatively, the patient would have to lay around for so long that so many other issues would present themselves in terms of blood clots, bed sores, possibly pneumonia or a pulmonary embolism, that really a surgery is absolutely necessary. Typically, I like to perform these surgeries within 24 to 48 hours after the patient experiences the fracture in order to get that patient up and mobilizing as quick as possible. Most studies have shown that patient success rate or patient longevity decreases if the hip is not fixed within 48 hours. After the patient is worked up by the medical team and cleared for surgery, we would then proceed to the operating room. There are different types of hip fractures. Not all hip fractures are the same. So a hip fracture is a very general term. The fracture can happen anywhere along the hip. The first place the fracture can happen is right below the ball of the hip or right below the femoral head. This is what we term a femoral neck fracture. With a femoral neck fracture, typically the blood supply to the femoral head is sacrificed. So even if we were able to realign that fracture and fixate it with screws, there would be a very high likelihood that the head of the femur, the ball of the femur, would subsequently die due to lack of blood flow. We call that avascular necrosis. If that were to happen, the patient would require a hip replacement. For that reason, especially in any patient older than 50 and sometimes older than 40, with a femoral neck fracture, the recommendation is typically for a hip replacement. With a hip replacement, there's two different types of hip replacement we can perform. We can perform a hemiarthroplasty in which just the ball of the femur is replaced, or we can perform a total hip replacement in which the ball is replaced and the socket is replaced. A lot of different factors go into the decision making on whether we perform a hemiarthroplasty or a total hip arthroplasty. In general, if a patient is healthy and relatively active at baseline and is ambulating prior to this injury with no assisted device, my recommendation would be for a total hip replacement, especially in a patient under 80 years old. In an older patient, definitely older than 80, or a patient with a lot of medical comorbidities and a lot of medical issues, and possibly a patient that's activities are not as high, and certainly a patient that at baseline is ambulating with either a walker or some type of assisted device, the recommendation would be for a hemiarthroplasty. The total hip arthroplasty takes a little bit longer than the hemiarthroplasty, and there's some slight more risks in terms of the prosthesis dislocating, but most of the studies have shown that patient outcomes are a little bit higher with the total hip replacement versus the hemiarthroplasty. With either replacement option, the surgery is typically less than 90 minutes, and a patient can put weight on this immediately after surgery. The goal is to get the patient ambulating as soon as possible after surgery, definitely by the next day. The next type of fracture is what we call an intertrochanteric hip fracture, and that would be a fracture that is a little bit lower down than the femoral neck, but goes through what we call the greater and lesser trochanter of the femur. With these fractures, we are typically going to fixate these with some type of rod and screw device. These surgeries typically last less than 60 minutes, and it's relatively minimally invasive for what it is. A small incision is made up in the buttock, and a canal is reamed into the femur in which we pass a rod. There is then a couple of extra small incisions along the leg in which we place a large screw into the femur or the femoral neck in order to fixate that. There's another small screw that's placed at the end of the rod in order to further fixate the rod into the femur. The last location for the hip fracture could be what we call a subtrochanteric femur fracture, in which the fracture occurs below the lesser trochanter, so a little bit even further down the hip. Again, this fracture is fixed with a rod. When compared to an intertrochanteric hip fracture, a lot of times these are a little bit more difficult surgeries and always require the use of a longer rod compared to the others. But it's still a surgery in which the hip is fixed with a rod and a screw. With both of these surgeries that are fixed with a rod and screw, the patient again is full weight bearing as tolerated immediately after surgery. It's really important to try to mobilize a hip fracture patient as quickly as possible in order to prevent some other medical issues from arising. I think one of the biggest variables with this surgery is definitely a patient's cognition. So if a patient comes in with any kind of underlying dementia or confusion at baseline, a lot of times after a hip fracture surgery, that dementia or confusion can get worse for some amount of time. And that's what makes the recovery of these types of hip fractures incredibly variable. In a patient with very good underlying health at baseline, sometimes these patients can recover relatively quickly and actually be discharged to home. On the other hand, patients with a lot of medical comorbidities or underlying dementia can take much longer to recover and sometimes can never fully recover from this surgery. Most of those types of patients end up being discharged to some type of rehab facility or skilled nursing facility until they return to a level in which their family members can help take care of them at home. In general, my goal with this surgery is always to get a patient back to ambulating the way they were before the surgery. So if that's a patient who's ambulating with no assistive device, then my goal is to get them back ambulating the same way. If they were using a cane beforehand or a walker beforehand, then again, I would like for them to get back to that level of ambulation. Typically, I'll follow up with a patient about 3 weeks after the surgery to remove the stitches, and we'll then again see the patient about 8 to 10 weeks post-op to monitor progress and get a new x-ray. A lot of times it can take close to a year for a patient to fully recover from this surgery.